Welcome to the deep dive. You know, preparing for the MSRA Situational Judgment Test, the SJT, can feel a bit like trying to solve a medical ethics riddle while, well, juggling flaming chainsaws, right?
Something like that.
It's not just about what you know, it's about how you think under fire. Today, we're cutting through the noise to give you some real-world mental tools. The high-yield rules, the traps to dodge, and those golden mnemonics so you can ace those tough professional dilemmas with confidence.
Absolutely. And we're really trying to cut through the jargon here. We're taking those dense UK guidelines, everything from GMC principles to the specifics of the Mental Capacity Act, and boiling them down into something you can actually use right here, this deep dive.
Okay.
Consider it your essential shortcut to being well-informed and confident for this vital part of your journey.
Okay, let's unpack this. Before we dive into the specific scenarios, we need a quick micro-primer on how to approach the SJT. What's the core mindset, that guiding star, for our listeners?
Right. Your guiding star in the SJT, and frankly in all of medicine,
Right.
is consistently prioritizing patient safety above all else. Every single decision, every action, it should loop back to how it impacts the well-being and safety of the patient. That's number one.
And flowing from that core principle, I suppose, remember to always act with honesty, adhere strictly to legal frameworks, apply proportionality in your actions.
Exactly.
And crucially, escalate concerns early when a situation is truly beyond your capacity or competence. It's about being pragmatic while holding true to your ethical compass.
And here's perhaps the simplest but most overlooked rule. If it's not documented, it didn't happen. Clear, contemporaneous documentation is your shield and your guide in, well, pretty much every scenario. It validates your actions and ensures continuity of care.
Absolutely vital. Okay, with that fundamental mindset firmly in place, let's begin our deep dive into our first major area, ethics and law. We're starting with the absolute bedrock of patient care, consent in adults.
Okay, so for the SJT, the core insight with consent is really moving beyond the idea of just a signed form.
Right, it's more than ticking a box.
Exactly. It's a dynamic process. It's about a voluntary, informed decision made by a patient with capacity after a genuine two-way conversation. This ensures patient autonomy and shared decision-making, which are, cornerstones of UK healthcare.
So what are the absolute must-knows from UK guidance on consent? What should people really focus on?
Well, first off, the GMC's decision-making and consent framework really pushes shared decision-making. It's about tailoring information and supporting the patient's understanding rather than just delivering a monologue, And that leads directly to Montgomery, 2015, where the Supreme Court made it crystal clear. It's not enough to list generic risks. You must highlight material risks. Those risks a reasonable person in that patient's specific position would find significant.
Right, patient-specific.
Precisely. And discuss reasonable alternatives, including the option of no treatment. That's a huge shift, demanding a real conversation, not just a formality.
I've seen this one trip people up so many times. Judging a patient's refusal as incompetent simply because you disagree with their decision. That's a crucial distinction, isn't it? It's tempting to think, oh, they don't understand, but...
It absolutely is. Tempting, but wrong. An adult with capacity has the right to refuse treatment, even if that decision risks serious harm or death. An unwise decision, as you see it, does not equate to a lack of capacity.
Okay.
If capacity is in doubt, then you follow the Mental Capacity Act, MCA 2005 principles. Always presume capacity first, actively support decision-making, and only if truly absent, act in their best interests using the least restrictive option.
And the pitfalls? Relying on the form?
That's a major one. Relying purely on a signed form without that genuine discussion. Or giving generic risks instead of patient-specific ones as Montgomery demands. It's paternalistic and legally insufficient.
Okay, let's run through a classic scenario. You're explaining two different management options for a patient, say surgery versus conservative management, both with different risk profiles. What's the best next step?
The optimal approach, the one the SJT is looking for, is a thorough shared decision-making process. Clearly explain all material risks for both options, including no treatment and reasonable alternatives. Explore what matters most to this patient, their values, their priorities.
And checking they've understood.
Yes, use the teach-back method to ensure understanding. Then, respect and document their informed choice and the agreed plan. Simply explaining only the procedure you think is best is paternalistic, outdated, and legally insufficient. That's often the tempting but wrong answer in the exam.
Got it. To help you remember this, we have a mnemonic for you. Material. That's meaningful risks. Alternatives, tailored info involve values. Enough time, record Ask Teach Back Law at Montgomery.
And for your rapid checklist in the exam, think.
1.
Prepare. What's the decision? Alternatives, even no treatment, and what matters to this patient.
2.
Dialogue. Explain material risks, benefits, uncertainties using plain language. Aids like diagrams can help too. Check capacity. If in doubt, apply the MCA's two-stage test for this specific decision now. Address any reversible causes first.
And finally,
Document. Record everything. Discussion, risks highlighted, alternatives offered, patients' values and questions, their final decision, and the agreed plan. Meticulously.
find the free SJT textbook and podcasts at passthemsra.com and subscribe at youtube.com at passthemsra.
So we've talked about adult choices, but what about our younger patients? Consent in children and young people involves a whole different set of rules, doesn't it? A bit more nuanced, perhaps.
It really does. Consent for under 18s is complex, hinging on age, competence, parental responsibility, and always their best interests. For under 16s, their ability to consent depends on Gillick competence.
Right.
While specific Fraser guidelines apply to sensitive areas like contraception, and those aged 16-17 are generally treated as adults for consent purposes.
Okay, so let's break that down. What are the key rules for under 16s?
Well, for under 16s, they can consent if deemed Gillick competent, meaning they have sufficient understanding and maturity for that specific decision at hand.
And if they're not competent?
Then consent must be sought from someone with parental responsibility, PR, and you must act in the child's best interests.
Okay, and for the 16, 17-year-olds?
They are legally presumed able to consent to treatment as if they were adults, as per the Family Law Reform Act, FLRA 1969, Shell.8. However...
It was a however.
Right. In cases of serious disagreement or refusal of life-saving treatment, that's when you'd need urgent senior or even legal input, potentially court intervention.
And the Fraser guidelines, they're specifically for things like contraception for under 16s, right? Even without parents knowing.
Exactly. They provide that very specific framework for providing contraception or sexual health advice to under 16s, even without parental knowledge or consent, if strict criteria are met.
Such as
They understand the advice, they can't be persuaded to involve parents, they're likely to continue having sex, their health is at risk without care, and it's in their best interest. You have to meet all those criteria.
That's a high bar. What are the common mistakes people make here in SJT scenarios?
A big one is assuming the Mental Capacity Act rules for adults apply unchanged to under 16s. Tempting, but wrong, because children's consent follows these specific Gillick and Fraser competence principles.
Okay.
Another is insisting on parental consent when a young person has been assessed as Gillick competent. Again, tempting, but wrong. A competent minor's decision should be respected, within the bounds of safeguarding, of course.
And confidentiality.
Breaching a young person's confidentiality without a clear safeguarding basis or without discussing its limits first is a major pitfall. And providing contraception without rigorously applying those Fraser criteria.
Let's consider a classic scenario. A 15-year-old requests contraception and explicitly refuses to involve their parents. What's the best next step?
Right. You should thoroughly assess their Gillick competence for this specific decision. If they are deemed competent, you must then apply the Fraser guidelines.
So you encourage parental involvement but don't insist.
Exactly. Encourage it, but respect their confidentiality within appropriate safeguarding limits. Offer contraception, maybe condoms too, STI screening, and meticulously document the entire assessment, the discussion, and your decision.
And the wrong answers.
Refusing to provide contraception until a parent attends, or immediately telling their parents regardless of competence, these ignore both Gillick competence and Fraser guidelines, potentially leading to unsafe outcomes and, well, a massive breach of trust.
Okay, so for your memory, use Gillick-A-Dam. Gauge maturity. Information understood. Look at risks alternatives. Involve parents. Encourage confidentiality limits. Keep best interests central.
And for your rapid checklist in the exam, remember to
1.
Identify age and urgency. Determine their age and if it's an emergency. Under 16. Assess Gillick competence for the specific decision. Encourage parental involvement, but don't insist if competent.
3.
Fraser pathway. If it's for contraception, STI, or termination, rigorously apply the Fraser criteria.
4.
Age 16-17. Take consent as from an adult. If refusing potentially life-saving treatment, seek urgent senior legal advice.
And 5.
Document. Record your assessment, info given, who is present, competence finding, consent refusal, plan, and safety netting.
Find the free SJT textbook and podcasts at passthemsra.com and subscribe at youtube.com at passthemsra.
Following on from Gillick competence and adult consent, the Mental Capacity Act provides a robust and specific framework for assessing decision-making ability when capacity is in question for those aged 16 and over.
Yes, capacity under the MCA 2005. It's about a person's ability to make a specific decision at the time it needs to be made. It's absolutely fundamental for ensuring decisions for adults, 16 plus, who might lack capacity are made legally, ethically, and importantly, in their best interests.
Right, and those 5 core principles are key, aren't they?
Absolutely foundational. Let's run through them quickly.
Got it.
You must presume capacity unless proven otherwise. Start there.
2.
Actively support decision-making. Do everything you can to help them make their own choice.
3.
Recognize that an unwise decision does not mean a lack of capacity. This trips people up constantly.
4.
If capacity is lacking, you must act in the person's best interests.
And 5.
Always choose the least restrictive option that achieves the purpose.
Yeah.
Okay, and then there's the 2-stage test for actually assessing capacity. Can you break that down for us?
Sure. Stage 1. Is there an impairment or disturbance in the functioning of the mind or brain? Think delirium, dementia, severe learning disability, intoxication.
Okay.
If yes, then stage 2. Can the person functionally understand, retain, use, or weigh, and communicate the relevant information for this specific decision now? It's always decision-specific and time-specific.
So you can lack capacity for one decision but not another.
Exactly. You might lack capacity to consent to complex surgery, but retain capacity for, say, deciding what to have for lunch. It's not a blanket judgment.
What are the common pitfalls here? You mentioned unwise decisions.
Yes, equating an unwise or risky choice with a lack of capacity. The MCA explicitly allows individuals to make decisions others might consider unwise if they have capacity.
What else?
Skipping essential support measures before assessing, providing extra time, communication aids, interpreters, a quiet environment, pain relief. You must try to maximize capacity first. That's tempting to skip when busy, but it's wrong.
And being specific.
Right. Using broad labels like the patient has no capacity instead of making decision-specific findings like lacks capacity for this treatment decision today, and making best interest decisions without clearly showing you considered their past wishes or values or reasoned why it's the least restrictive option.
And the IMCA, the Independent Mental Capacity Advocate.
Yes, forgetting the crucial step of instructing an IMCA when the legal criteria are met, that's usually when someone lacks capacity for serious medical treatment or a change in accommodation, and they have no appropriate family or friends to consult. It's a safeguard.
Okay, classic scenario time. A delirious, hypoxic patient refuses urgent IV antibiotics. They're agitated and disoriented. Best next step.
First, you must optimize their physiological state and environment to maximize any fluctuating capacity. So, oxygen, maybe fluids, pain relief if needed, quiet space.
Try and clear the delirium a bit first.
Exactly. Then, apply the 2-stage test for capacity for this specific decision now. If, after support, they still lack capacity, you must treat them in their best interest using the least restrictive option necessary to prevent serious deterioration. And document every single step, your assessment, your rationale, and a plan to review capacity once the delirium hopefully improves.
And the wrong approach.
Simply respecting the refusal without assessment is unsafe and neglects your MCA duty. Calling security and proceeding without assessment or documentation is disproportionate, potentially unlawful, and fails to uphold patient rights.
Got it. For your memory, we have the mnemonic, 4C best. That's cause impairment. Continue, retain. Compare your use way. Communicate then for action if lacking capacity. Best interests, least restrictive, share views, time to review.
And the rapid checklist for the exam.
1.
Consider triggers and safety. If a choice has serious risk or the person seems confused, delirious, consider capacity. Treat emergencies first while assessing.
2.
Maximize capacity. Optimize physiology, timing, privacy, provide interpreter seds, use small chunks of info, teach back.
3.
Apply 2-stage test. Identify impairment, then apply the 4 functional abilities. Understand, retain, use way, communicate for this decision now. Record evidence for each bit, if lacking capacity. Follow the S.4 best interests checklist. Involve those close. Consider ADRT SLPAs. Choose least restrictive option. Document reasoning. Record thoroughly. Detail support given, findings for each limb of the test, who was consulted, best interest reasoning, and plan for review. Find the free SJT textbook and podcasts at passthemsra.com and subscribe at youtube.com at passthemsra.
Understanding capacity is absolutely paramount, particularly when we approach the profoundly sensitive subject of end-of-life decision-making, where patient wishes and legal instruments carry really significant weight.
Yes, end-of-life decisions involve such a delicate balance, don't they? Clinical judgment, legal requirements, individual patient values. We're talking about things like DNACPR orders, ADRTs, advanced decisions to refuse treatment, and LPAs, lasting powers of attorney. Understanding these is crucial to ensure care aligns with patient wishes and, well, the law.
Absolutely. And crucially for the SJT, let's nail this, a DNA CPR order applies only to attempted cardiopulmonary resuscitation. That's it.
So all other care continues.
Yes, all other appropriate medical care like antibiotics, oxygen, analgesia, fluids, general escalation should continue. Decisions must be individualized, avoiding those blanket policies.
That's a huge pitfall, isn't it? Assuming DNA CPR means stop all active treatment.
It's a massive one. Tempting perhaps if you're rushed, but wrong. It can lead to withholding vital appropriate care and implementing blanket DNA CPR orders, say, for all residents in a care home, is unlawful and discriminatory.
Okay, what about ADRTs and LPAs?
An ADRT, an advanced decision to refuse treatment, can be legally binding if it's valid and applicable. Big if. If it refuses life-sustaining treatment, it must be in writing, signed by the person, witnessed, and explicitly stated applies, even if their life is at risk.
And LPAs.
A lasting power of attorney, LPA for health and welfare, allows a named person, their attorney, to make decisions when the patient lacks capacity. They must always act in the patient's best interests and within the authority granted in the LPA document. Importantly, though, LPAs cannot demand clinically inappropriate treatment.
Right.
And the GMC guidance on treatment and care towards the end of life really stresses involving patients early in these discussions, being honest about uncertainties, regularly reviewing goals of care, respecting valid ADRTs and LPAs, and meticulously recording everything.
Okay, classic exam scenario. A capacitated patient with advanced heart failure asks you about signing a DNR. What's the best next step?
Right. You need to explore their values and goals of care first. Then, explain what CPR realistically involves and its likely outcomes for someone with their specific condition. Crucially, clarify that a DNA CPR applies only to attempted resuscitation and that all other appropriate treatments will continue.
Then what?
Then you agree on and review a personalized care plan, maybe using a respect form or similar, and ensure everything is meticulously documented.
And the wrong answer.
Explaining DNA CPR as no active treatment from now on, that's just fundamentally wrong and misleading. Or refusing to discuss it because it's distressing that avoids your professional responsibility.
Okay, for a quick memory hook, remember DNA CPR, AD&T do not treat. CPR only. Other appropriate care continues.
And the rapid checklist for the exam.
1.
Check capacity and wishes first. Explore goals, values, ask about ADRT SLPAs, offer advanced care planning. Discuss DNACPR early and sensitively. Explain realistic CPR outcomes, clarify other treatments, continue, avoid blanket decisions if capacity lacking. Follow MCA best interest checklists, consult family attorneys, consider ADRT SLPAs, choose least restrictive, document rationale.
4.
Respect lawful instruments. Adhere to valid applicable ADRTs. Work with LPAs within their authority and best interest duty.
5.
Document clearly. Record who was involved, info given, decisions made, DNA CPR respected, RDTLAA, and review triggers. Find the free SJT textbook and podcasts at passthemnpr.com and subscribe at youtube.com at passthemSRA.
As we plan for individual patients, we absolutely must also consider the broader ethical challenge of how finite healthcare resources are fairly distributed across the population. That's a constant tightrope walk in the NHS, isn't it?
It really is. Fair allocation, or resource allocation and fairness as a topic, means using finite time, staff, equipment, beds, you name it, to maximize patient benefit, reduce harm, and crucially, avoid unlawful discrimination. It requires transparent decision-making and clear escalation when limits are reached.
So what guidance helps us here?
GMC Good Medical Practice 2024 is clear. You must treat patients fairly, avoid discrimination, make good use of resources, and choose sustainable solutions when clinically possible without compromising care. The NHS Constitution also upholds principles of fairness and quality.
And what about tackling health inequalities, specifically in resource decisions?
That's where the equality and health inequalities duties come in. NHS organizations have to consider protected characteristics and health inequalities. This includes using frameworks like Core 20 PL/US 5 to target resources towards deprived populations and priority clinical areas, aiming to reduce those inequalities.
So a common pitfall would be
Hidden discrimination based on things like age or disability, or just ignoring the wider health inequalities duty when allocating resources. It's tempting maybe to go with first come, first served or the loudest voice, but that's wrong because it can be unlawful and worsen inequities. You need objective clinical need and potential benefit as your guide.
And failing to escalate.
Yes, failing to escalate capacity risks to seniors or operational leads like bed managers when limits are genuinely reached is another big one.
Okay, classic exam scenario. 2 CT slots left in a busy ED. Patient A has suspected PE, PERC positive, tachycardic. Patient B has a chronic back pain MRI request from weeks ago. How do you prioritize?
You must use clinical urgency and potential benefit. The CT for suspected PE for patient A has to be done now. It's an immediate, potentially life-threatening condition.
And patient B?
The MRI request for patient B should be deferred, but with clear safety netting advice and a realistic time frame for rescheduling. In this decision, the rationale, any escalation plan if more acute cases appear, must be thoroughly documented.
So scanning based on who arrived first is wrong.
Completely ignores clinical need. Demonstrates poor clinical judgment and resource stewardship.
Right. For a memory hook, think brand plus. Benefits or risks, alternatives do nothing. Applying that to the resource decision. Plus, thinking about equity and evidence.
And the rapid checklist for the exam.
1.
Clarify criteria. Define clinical urgency, expected benefit, risk if delayed, inequality factors. Apply consistently.
2.
Be transparent. Document your logic. Communicate timeframes. Offer safety netting. Escalate early. If demand exceeds safe thresholds, involve seniors, operational leads, bed managers. Use shared decision-making, SDM. Discuss reasonable options. If clinically equivalent, consider lower burden, safer, or greener pathways, thinking greener NHS too.
5.
Apply inequalities lens. Actively check for and mitigate barriers, example, language disability, using AIS principles. Find the free SJT textbook and podcasts at passthemsra.com and subscribe at youtube.com at passthemsra.
Our duty to fair resource allocation naturally extends into ensuring equality, diversity, and inclusion in every aspect of healthcare delivery, doesn't it? Creating a system that works for everyone.
Absolutely. So equality, diversity, and inclusion, EDI, in healthcare means treating people fairly and lawfully, respecting all those protected characteristics, actively removing access barriers, whether communication, disability, language, and proactively tackling discrimination and harassment. It's fundamental for fair access, safe care, and building trust.
The cornerstone here is the Equality Act 2010, right?
Yes, absolutely key. It makes discrimination unlawful based on 9 protected characteristics: age, disability, gender reassignment, marriage, civil partnership, pregnancy, maternity, race, religion or belief, sex, and sexual orientation. You need to know those.
And GMC guidance.
GMC Good Medical Practice 2024 sets out your professional duty to treat patients and colleagues fairly, actively help tackle discrimination, and communicate clearly and kindly with everyone. And NICE guidance on patient experience reinforces respect, dignity, empathy, and accessible information.
You mentioned accessible information, the AIS standard again.
Yes, the Accessible Information Standard, AIS, is so important. It's a legal requirement for NHS and publicly funded adult social care. You must identify, record, flag, meet, and review the communication needs of patients. That means providing BSL interpreters, easy-read materials, large print, whatever is needed.
What are the common traps the SJT sets here?
A big one is using relatives, or worse, children, as interpreters, except in the most extreme, life-threatening emergencies. It's tempting when you're busy, but it's wrong. It risks accuracy, confidentiality, and puts undue burden on family. What else?
Ignoring microaggressions or discriminatory jokes in the workplace. Again, tempting to let it slide, but wrong because it normalizes harmful behavior. Implementing blanket policies that inadvertently cause indirect discrimination, like having only online booking available, and refusing care based on perceived lifestyle choices, which the GMC explicitly prohibits.
Okay, classic scenario. A deaf patient attends a non-urgent clinic appointment, and a BSL interpreter isn't there, despite being requested. Best next step.
You have to intervene immediately. Arrange for a qualified BSL interpreter to attend at the earliest safe opportunity as per the AIS. Provide accessible written info in the meantime, safety net any urgent concerns, and meticulously document what happened and the plan.
And just trying to shout or lip read.
Ineffective, disrespectful, and fails your AI's duties. Proceeding using the patient's child is unsafe and breaches guidelines.
Got it. For a quick memory hook, remember AIS 5. Ask, record, flag, meet, review, communication needs.
And the rapid checklist for the exam.
Done.
Spot barriers early. Actively identify potential communication access barriers, language, sensory loss, learning disabilities. Arrange adjustments promptly per AIS.
2.
Use professional interpreter. Always arrange qualified interpreters. Avoid family unless extreme emergency. Documenting rationale.
3.
Zero tolerance of discrimination. Challenge inappropriate remarks clearly. Support those affected. Know how to report escalate. Support shared decisions. Ensure info is understandable. Use teachback. Offer decision aids. Escalate and record. Follow local policy for reporting, example, DATIX. Document facts, actions, outcomes. Find the free SJT textbook and podcast at passthemsra.com and subscribe at youtube.com at passthemsra.
Right, so beyond simply avoiding discrimination, actively managing cultural differences helps us deliver truly patient-centered care, acknowledging and integrating their unique beliefs and values into the plan.
So managing cultural differences means proactively working with patients' values, beliefs, and practices to co-produce a safe and acceptable plan of care. This requires balancing respect for diversity with adhering to equality law, safeguarding duties, and core clinical standards.
Yes, and GMC Good Medical Practice 2024 stresses treating patients fairly, kindly, without discrimination, and adapting your communication style. And the GMC guidance on personal beliefs in medical practice is crucial here too.
How so?
It clarifies you must not deny access to appropriate services based on your personal views, nor should you impose your own beliefs on patients. You need to manage any conscientious objections appropriately.
And using interpreters. It's still key here.
Absolutely critical. The Accessible Information Standard, AIS, and interpreting guidance use qualified professional interpreters, avoid family children except in genuine emergencies, and always document why if an exception is made.
What are the pitfalls here? Dismissing beliefs.
Yes, dismissing deeply held beliefs or trying to coerce a patient into a decision that conflicts with their values is a major one. Relying on relatives as interpreters is another recurring pitfall. Ignoring subtle safeguarding cues related to cultural practices. Failing to document the rationale for decisions accommodating cultural preferences. And stereotyping, assuming all patients from X will want Y.
Okay, classic scenario. A patient clearly and consistently refuses blood products for religious reasons, and an elective surgical procedure is planned. Best next step.
Right. First, respectfully explore their beliefs, fully understand their reasons, then discuss and plan reasonable alternatives with the patient. This involves the anesthetics and surgical teams to explore blood-sparing strategies.
Assuming they have capacity.
Yes, confirm their capacity for this decision. Ensure fully informed consent is given for the alternative plan, and meticulously document the discussion and the agreed care, including any advanced planning.
And the wrong answers.
Proceeding as planned because you deem the refusal unwise, or refusing to treat the patient outright, both are breaches of autonomy and professional duties, unethical and potentially illegal. For a memory hook. Respect. Rapport, explore beliefs. Support understanding. Propose options. Ethics law, consent capacity, traceable notes.
And the rapid checklist for the exam.
What?
Explore first. Ask open questions like, what matters to you about this? Understand beliefs. Key decision makers.
To
Support understanding. Use professional interpreter, culturally appropriate materials, teach back method.
Sorry?
Co-produce a safe plan. Offer reasonable alternatives respecting beliefs where possible. Clearly explain non-negotiable legal or safety boundaries.
4.
Safeguard. If cultural beliefs practices raise risk of harm, escalate to safeguarding. Share info lawfully. Document reasons. Document and follow-up. Meticulously record who was present, discussion, agreed plan, review points, safety netting. Find the free SJT textbook and podcasts at passthemsra.com and subscribe at youtube.com at passthemsra.
Okay, so we've covered a lot on ethics and law. Now, as doctors, our ethical and legal duties are constant, but the practicalities of a busy NHS environment demand skilled time and resource management. Let's dive into how you can effectively juggle those demands.
Right. Section 7, time and resource management. Starting with prioritizing clinical tasks. This means ordering your work to minimize harm and maximize benefit. It's fundamentally about addressing the sickest first.
Always.
Handling time-critical issues before routine ones, ensuring clear ownership, providing appropriate supervision, and escalating early when needed, all underpinned by thorough documentation.
And sickest first means what in practice?
It means always assessing patients using the ABCDE approach, responding immediately to high nudie WS2 triggers, looking for sepsis red flags, managing acute chest pain ACS, adhering to stroke windows, and addressing immediate threats like anaphylaxis or active bleeding. That's your absolute priority.
And chasing results.
Time-critical results, yes.
Yeah.
Act on and chase critical values, urgent radiology alerts, significant ECG changes immediately, and document your actions clearly.
How do you keep track when it's chaotic?
Using a visible plan helps, like a now, next, later board. Assign clear owners and deadlines for each task. Ensure regular checkbacks. Delegate safely, right task, right person, clear brief, appropriate supervision, check understanding. And escalate early. Involve your registrar, consultant, or site team when acuity or volume exceeds your resources or competence.
Okay, what are the major pitfalls the SJT loves to test here?
Prioritizing tasks on a first-come, first-served basis rather than by clinical risk and benefit. Tempting when you're overwhelmed, but wrong because it compromises patient safety. Chasing low-value admin tasks while critical results or deteriorating patients are waiting. Operating with hidden work, no visible plan, no assigned owners, failing to escalate. And of course, failure to document critical decisions or safety netting advice.
Classic scenario time. You receive 2 simultaneous urgent bleeps. One for a new chest pain patient with dynamic ECG changes, and another for a routine drug chart rewrite. Best next step.
Your immediate priority is the chest pain patient with ECG changes. Initiate the ACS protocol. Concurrently, ask the nurse in charge to pause the paperwork for the drug chart and delegate that rewrite to a safe and available colleague with a clear deadline and brief.
And doing the drug chart first.
Rewriting a routine drug chart first to clear quick jobs, or worse, finishing your emails before responding to a potentially life-threatening cardiac event is a dangerous misprioritization. Shows poor clinical judgment.
Okay, memory hook.
Yeah.
Now, next later, plus ODT, which is owner deadline threshold to call.
And the rapid checklist for the exam.
1.
Scan for lifeline threats.
Yeah.
Immediately assess using ABCDE. List tasks by harm time. Categorize by potential harm if delayed, and time critical windows, organelle, sepsis antibiotics within 1 hour.
3.
Make a visible plan. Now, next later, board list. Assign owner deadline. Agree escalation thresholds.
4.
Delegate safely. Delegate routine clerical tasks appropriately, reserving focus for high-risk decisions deteriorating patients.
5.
Review and document. Recheck task board frequently. Update items, close loop on completed tasks, ensure clear handover documentation. Find the free SJT textbook and podcasts at passthemsra.com and subscribe at youtube.com at passthemsra.
Even with excellent prioritization, working under time pressure is just, well, part of the job in clinical practice. It's how you manage that pressure with calm and structure that defines your safety and effectiveness.
Exactly. So working under time pressure, this means adopting short, deliberate structures to reduce the risk of error. Techniques like initiating micro-huddles, using timers, deliberately single-tasking critical steps, and employing clear communication. These strategies help maintain safety and efficiency when time is really short.
Can you give examples of those structures?
Well, pause, plan, prioritize, even for a quick decision. Take a brief 30-second pause, maybe huddle mentally or with a colleague, to decide your now, next, later priorities. It sounds simple, but it stops reactive chaos.
And single tasking.
Yes, single-task critical actions. During high-risk procedures or moments prescribing, defibrillation, complex consent talks, dedicate your full attention to that single task. Avoid multitasking then. It's a major pitfall, engaging in chaotic multitasking during high-risk activities. Tempting when you feel rushed, but wrong because it significantly increases error risk.
Closed-loop communication is important too, isn't it?
Hugely. When delegating or handing over, ensure clarity. State the name of the person, clearly define the task, specify a time for completion or checkback, and crucially ask for confirmation back. Nurse Smith, please confirm you will prepare the fluids within 5 minutes.
And escalating. Still key.
Absolutely. Know and communicate your escalation thresholds. If you anticipate missing deadlines or safety thresholds due to workload, involve a senior colleague or the site team immediately. Failing to escalate when overwhelmed, trying to suffer in silence is another major pitfall.
Okay, classic scenario. You're managing a busy ward. 3 urgent bleeps arrive simultaneously, 1 for a deteriorating patient, 1 routine query, 1 a call from a relative. Best next step.
Your immediate best action is to call a brief 60-second huddle, even if it's just a mental one in your head. Rapidly allocate tasks by risk. You attend immediately to the deteriorating patient, ensuring they're stable. You might ask a colleague to handle the less urgent bleeps or calls, setting a clear, say, 20-minute regroup time to check in. Document this plan on your task board or in your notes.
And just answering them one by one.
Answering each bleep sequentially without a plan wastes critical time for the sickest patient. Switching tasks every minute to do a bit of everything leads to fragmented attention, increased error risk, and likely means no task is completed effectively.
Got it. Memory hook. Pace, pause, assign clock timers, escalate.
And the rapid checklist for the exam.
1.
Call a huddle. Initiate a brief 60-second huddle, or mental pause, to list top 3 safety risks.
2.
Assign tasks. Clearly assign tasks with owners and deadlines. Set a specific regroup time to review progress.
3.
Protect focus. Safeguard focus windows for high-risk steps. Politely deflect lower-value interruptions during these times.
4.
Use scripts. Employ phrases like, "I'll call you back in 5 with an update," to manage expectations and interruptions effectively.
5.
Record and escalate. Document key decisions and update your task board. Escalate to a senior if slippage threatens patient safety. Find the free SJT textbook and podcasts at passthemsrga.com and subscribe at youtube.com at passthemsra.
Time pressure is often, as we said, a symptom of managing multiple demands simultaneously. So let's explore how to stay on top of that mountain of tasks efficiently and safely.
Right, managing multiple demands. This involves the structured triage of all incoming inputs, whether it's bleeps, calls, results, requests from relatives using a visible plan, safe delegation, and timely escalation. This system prevents tasks from getting missed and helps you maintain control in a busy environment.
What's the core principle here?
A single intake list. All incoming work should land on one central board or list. Avoid multiple private lists scattered around. Each item should ideally have an ODT assigned owner, deadline, threshold for escalating.
And what's a common mistake people make?
Maintaining multiple private to-do lists. It's easy to do, but often leads to important jobs being lost or forgotten. Another is answering every interruption instantly without any form of triage or prioritization. Tempting maybe seems efficient, but wrong because it destroys focus and prevents efficient task completion.
So how do you handle interruptions then?
You need focus windows. Actively protect periods of time for high-risk tasks like prescribing or complex consent. Politely deflect lower-value interruptions during these crucial windows. And use batching. Group similar, lower-value tasks together, like making all results calls at once or writing multiple discharge letters. Dedicate specific time boxes for these sprints.
Escalation thresholds again.
Yes. Pre-agree clear thresholds with your team or seniors for escalation, like, if we have UDA2 deteriorating patients or waits exceed X minutes, call the register site manager. Failing to escalate despite a growing backlog and rising patient risk is a major pitfall.
Okay, classic exam scenario. While you are in the middle of prescribing insulin, 3 simultaneous demands arrive. Your phone rings, your bleep goes off, and a relative approaches you. Best next step.
Your priority is to protect the prescribing step from interruption. Politely tell the nurse or relative that you are in the middle of a critical task and will call back in 5 minutes for non-urgent matters, or ask for an SBAR if the bleep is urgent. Log all incoming demands onto your single task list with ODT, owner, deadline threshold to ensure nothing is missed.
And then what not to do.
Answering the phone on loudspeaker while prescribing or abandoning prescribing to attend to a non-urgent query significantly increases the risk of medication errors. These actions demonstrate poor task management and compromise patient safety.
Got it. Memory hook. ODT board equals owner deadline threshold on every item.
And the rapid checklist for the exam.
1.
Queue single. Direct all incoming inputs to one central list or task board. Avoid side queues.
2.
Triage urgency. Rapidly triage tasks by risk-benefit. Assign owners. Set clear return call windows for non-urgent items.
3.
Execute batches. Group similar lower-value tasks and time box them. For example, 15-minute sprints. Review progress. Make focus windows. Protect dedicated time for high-risk tasks. Politely deflect lower-value interruptions.
5.
Escalate. If capacity is exceeded or risk thresholds crossed, escalate to senior site team, clearly requesting help or task reallocation. Find the free SJT textbook and podcasts at passthemsra.com and subscribe at youtube.com at passthemsra.
Effective management of multiple demands often means being resourceful and innovative, doesn't it? Especially when faced with genuinely limited resources.
Exactly. Which brings us to effective use of limited resources. This means delivering the best possible patient outcomes with finite staff, time, beds, diagnostic capacity, while consistently maintaining fairness, safety, and thorough documentation. It's about being a good steward of NHS assets, really.
So what's the guiding principle?
Clinical value first. Only order tests or interventions that will genuinely change patient management. Avoid unnecessary duplication of tests. Always check prior results first.
And if there are equivalent options?
If 2 options are clinically equivalent in benefit and safety, choose the one with lower risk, burden, or cost. For example, opting for an ultrasound before a CT if it can answer the clinical question adequately. Think flow, too.
Flow thinking.
Yeah. Proactively engage in early discharge planning, ensure timely completion of TTOs, make early referrals to therapy services to prevent patient bottlenecks and improve bed flow, and maintain active communication with pharmacy, radiology, site managers. Use booking windows wisely.
What are the common pitfalls here?
Ordering just-in-case tests with no clear impact on management. Tempting, seems thorough maybe, but wrong because it wastes resources and delays care for others. Unnecessarily repeating labs or imaging without checking prior results. Ignoring coordination with pharmacy or therapy, leading to last-minute discharge delays. And failing to document resource constraints or escalate when delays create significant patient risk.
Okay, classic scenario. The CT list is completely full, but you have a patient with right upper quadrant RUQ pain where a focused ultrasound is indicated and can safely answer the clinical question. Best next step.
You should book an urgent ultrasound that directly addresses the clinical question. Provide appropriate safety netting advice if the ultrasound is negative, and document your decision thoroughly. If the patient's condition deteriorates, escalate immediately.
And not the CT.
Ordering a CT because it's more comprehensive, when a simpler, quicker test is sufficient, wastes a valuable resource and delays care for other patients. Delaying all imaging until tomorrow is unsafe if a diagnosis is time critical.
Got it. Memory hook. Brand. Benefits, risks. Alternatives, do nothing applied to test treatments.
And the rapid checklist for the exam.
1.
Verify prior results. Always check for existing test images to avoid repeats.
Huh?
Ask management impact. Define the clinical question. Choose test interventions that will actually change management.
3.
Least burden equivalent. If clinically equivalent options exist, select the one with lower risk, patient burden, or cost.
Core.
Unite teams flow. Coordinate proactively with pharmacy, therapy, site teams for smooth patient flow and timely discharges. Escalate and document. Promptly escalate when resource constraints threaten safety. Document choices and constraints thoroughly. Find the free SJT textbook and podcasts at pastmsra.com and subscribe at youtube.com/pastmsra.
Speaking of resources, one of the most precious is, of course, your own time and energy. Balancing your clinical workload with your non-clinical duties like teaching or quality improvement is a constant and often challenging act of self-management.
Yes, balancing clinical and non-clinical workload. This involves effectively meeting your primary clinical duties while simultaneously maintaining commitments to non-clinical responsibilities, teaching, supervision, governance, admin, without compromising patient safety or fairness to colleagues.
What's the absolute #1 rule here?
Safety first. Your overarching principle must be that clinical care and attending to deteriorating patients always take immediate priority over any pre-planned non-clinical work. No exceptions.
So planning is key.
Absolutely. Plan ahead. Be proactive in ring-fencing your non-clinical time. Arrange appropriate cover for meetings or teaching sessions well in advance, and clearly communicate your objectives and the cover plan to your team. Negotiate and inform your team, the nurse in charge, NIC, relevant rota leads about your commitments. Transparency avoids surprises.
And document the cover plan.
Yes, document agreements. Always record agreed cover plans, who is covering what, when, how to escalate. Email or notes on the rota work. And remain flexible.
Flexible how?
Review and flex. If clinical acuity on the ward suddenly rises significantly, be prepared to return to clinical work immediately and reschedule your non-clinical duties. Patient safety trumps the meeting or teaching session.
Common pitfalls. Leaving the ward short.
Yes, leaving the ward short-staffed or compromising patient safety to attend a non-clinical meeting without arranging appropriate cover. Tempting to just slip away, but wrong because it prioritizes convenience over safety. Insisting on delivering teaching during a ward surge is another. Failing to document cover plans leading to confusion, and secret swaps of shifts without informing leads undermines safety and fairness.
Okay, classic scenario. You are booked to deliver an important teaching session, but simultaneously, 2 patients on your ward begin to deteriorate rapidly. Best next step.
Your immediate priority is the deteriorating patients. You should cancel or postpone the teaching session, inform the relevant stakeholders like the education lead, your consultant, and perhaps offer to send materials or reschedule. Your primary responsibility is to remain on the ward to manage the clinical emergency. Document the decision.
And just going to the teaching anyway.
Leaving the ward with your phone off to avoid interruptions or trying to deliver the teaching and cash up later demonstrates a dangerous disregard for immediate patient safety.
Got it.
Yeah.
Memory hook. Use the urgent important grid to help prioritize.
Do now schedule delegate drop.
And the rapid checklist for the exam.
Why?
Scan clinical risk. If safe, proceed with non-clinical. If not, Immediately cancel arrange cover.
2.
Arrange appropriate cover. Identify suitable colleague. Brief clearly using SBR.
3.
Inform stakeholders. Notify Clinis Education Lead, NIC, switchboard if on call.
4.
Manage non-clinical tasks. Keep a short-to-finish list. Time box them. Review progress.
5.
Record outcomes and lessons. Document changes to plan. Reflect on lessons for future planning. Find the free SJT textbook and podcasts at pastthemsra.com and subscribe at youtube.com at pastthemsra.
Right, even the most meticulous doctors, the most organized ones, will encounter errors or complaints in their careers. It happens. How you handle these situations is really a mark of true professionalism, turning challenges into opportunities for trust and improvement. Exactly. Section 8, dealing with errors and complaints. Starting with responding to patient complaints. A complaint is any expression of dissatisfaction that requires a response. How you handle it is critical. It's an opportunity to restore trust, improve patient experience, and drive learning. Complaints must be handled promptly, compassionately, and in line with standards.
What are the key standards?
The NHS complaint standards, set by the Ombudsman, mandate you listen, respond effectively, learn, set clear plans, timescales, and offer fair remedies. The 2009 NHS complaints regulations outline the formal process: acknowledgement, investigation, response, signposting to Ombudsman if unresolved. And GMC Good Medical Practice 2024 advises clear communication, being fair, non-defensive, and actively using complaints to improve practice.
And apologizing.
Crucially, NHS resolution confirms offering an apology is strongly encouraged and is not an admission of legal liability. It's just good professional practice and active compassion.
Common pitfalls. Getting defensive.
Yes, becoming defensive or immediately blaming others when confronted, tempting, maybe instinctive, but wrong as it immediately erodes trust. Maintaining silence or delaying a response without a clear plan, ignoring the learning opportunity, refusing to log a complaint because it seems minor or informal, and improvising a solution instead of signposting to the formal complaints pathway or palace.
Okay, classic scenario. A patient's relative approaches you, upset, reports a receptionist was rude, and asks how to complain. Best next step.
Immediately listen empathetically to their concerns and thank them for raising the issue. Offer a sincere apology for their experience without admitting liability. Clearly explain the complaints process, including typical timescales, and provide details for palace interface, patient advice, and liaison service. Crucially, you must record the concern and ensure it's shared for organizational learning.
And what not to do.
Advising them to call head office and walking away, or immediately defending the receptionist and refusing to log the concern, is unprofessional, unhelpful, and contrary to NHS standards.
Memory hook, 3 A's, acknowledge, apologize, action plan.
And the rapid checklist for the exam.
1.
Listen and acknowledge. Thank them. Actively listen to understand their desired outcome.
2.
Apologize meaningfully. Offer sincere apology for experience. Outline next steps, named contact, timescales. Offer PALA's details.
3.
Immediate fixes. Resolve simple issues quickly, for example, rebooking while formal investigation proceeds. Record and escalate. Follow local policy to log complaint. Record for learning, example LFPSE if safety related. Escalate per trust procedure.
5.
Close the loop. Ensure timely written response, explaining findings, learning, remedies. Signpost to Ombudsman if needed. Find the free SJT textbook and podcasts at pastthemsra.com and subscribe at youtube.com at pastthemsra.
Sometimes, of course, the complaint stems from a direct medical mistake. In these instances, the ethical principle of candor, open, and honest disclosure becomes absolutely paramount.
Yes, disclosing mistakes. Candor means being open and honest when things go wrong. It involves promptly telling the affected person what happened, apologizing, explaining what is known, outlining the next steps for investigation and learning, and ensuring recurrence is prevented. This builds trust, fosters a learning culture, and it's a professional duty.
What's the key guidance here?
The GMC NMC Candour guidance outlines the professional duty to tell patients when something's gone wrong, apologize, offer remedy support, share known facts, avoiding speculation, and explain what happens next.
And the organizational duty.
That's CQC Regulation 20, the statutory duty of candor. It's an organizational duty for healthcare providers. It requires them to notify patients of notifiable safety incidents, provide a written apology, and keep records. As clinicians, you must escalate promptly to enable your organization to meet this duty.
And apologies again.
Yes, NHS resolution explicitly confirms apologizing is the right thing to do and is not an admission of legal liability. And all patient safety events, errors, near misses should be reported internally via LFPSE, learned from patient safety events, and responded to proportionately under PSIRF, Patient Safety Incident Response Framework for Learning.
Common pitfalls. Delaying disclosure.
Yes, delaying disclosure or offering a formulaic, non-genuine apology. Tempting to put it off, but wrong breaches both professional and statutory duties. Speculating about the cause or blaming others. Failing to accurately record the discussion or report the incident internally. Forgetting to offer practical support or remedy. And ignoring near misses because no harm occurred. You should still be open if it could have caused harm to stress and always report internally for learning.
Okay, classic scenario. You discover you mistakenly gave a patient 50 milligrams instead of 5 milligrams of a critical drug. Patient is stable, no adverse effects noted so far. Best next step.
Immediate priority. Ensure the patient remains safe, monitoring, etc. Then, inform your senior or line manager. Promptly and candidly apologize to the patient, explain what you know about the incident, outline next steps, e.g. monitoring review. Document this discussion thoroughly in the notes. Crucially, report the incident via the LFPSE system and ensure the Regulation 20 duty of Candour process is followed by your organization, if applicable.
And saying nothing.
Saying nothing because no harm occurred is a serious breach of the duty of candor and prevents vital learning. Waiting for the consultant to return next week delays crucial disclosure and reporting.
Got it. Memory hook. Real apology. Regret, explain, action, learn, no blame speculation.
And the rapid checklist for the exam.
What?
Immediate safety. Ensure patient's safe. Inform senior manager promptly. Speak with candor. Say sorry. Share known facts. No speculation blame. Explain next steps. Offer support.
3.
Document and notify. Record discussion meticulously in notes. Complete internal reporting, LFPSE. Follow Reg 20 if needed. Learn. Actively contribute to review investigation under PSIRF. Ensure feedback loops completed. Close loop with patient if appropriate to share learning. Find the free SJT textbook and podcasts at passthemsra.com and subscribe at youtube.com at passthemsra.
After an error, candor with the patient is essential, but equally vital is your own internal reflective practice to learn from the experience and prevent recurrence. It's not just about the system, it's about your own development too.
Absolutely. Reflective practice after an error. Reflection is a structured, honest, and usually anonymized account designed to help you understand what happened, what you learned from it, and what you will do differently in the future. It's a core professional activity, improves care, builds resilience, and fosters continuous professional development.
What's the official guidance on this?
The GMC Academy Reflective Practitioner guidance is clear. Reflective notes should be anonymized, no patient identifiers, balanced, considering all factors, not just self-blame, focused on learning and improvement, and can be shared in summary form, perhaps with your supervisor.
And it's about learning, not blame.
Exactly. Reflection operates within a just and learning culture. Its primary purpose is improvement, not individual blame. It should link to broader PSIRF learning processes where relevant. Effective reflection often follows a structured approach. What happened? So what? Insights impact, and now what? Concrete actions for the future.
And it should lead to actual change.
Ideally, yes. Identifying guidelines to read, skills to practice, suggesting system fixes. Learning should ideally be shared with the wider team, appropriately anonymized, of course.
Common pitfalls, including patient details.
Yes, including identifiable patient data, names, precise dates, unique characteristics in your reflective notes. Tempting to be specific, but wrong as it breaches confidentiality and can have serious consequences. Engaging in excessive self-criticism without clear learning points or actionable steps. Keeping insights entirely private, preventing wider learning. And confusing personal reflection with formal incident investigation.
Okay, classic scenario. You're tasked with writing a reflective note after being involved in a recent prescribing error. Best next step.
Use a structured approach like what? So what? Now what? Crucially, you must anonymize the reflection, no patient identifiers. Focus on identifying contributory factors, systems issues, personal factors, and list concrete actions you will take, maybe with target dates. Finally, consider how this learning can be shared appropriately, for example, at a safety huddle with your supervisor, without breaching confidentiality.
And what's definitely wrong?
Writing a blow-by-blow account with names and times severe breach of confidentiality. Deciding not to write anything in case you get into trouble misses a vital opportunity for learning and professional development and might even breach appraisal requirements.
Got it. Memory hook. WSN triangle. What, so what, now what?
And the rapid checklist for the exam.
1.
Use a structure. Employ what, so what, now what, or similar for clarity.
2.
Anonymize. Ensure no patient names, identifiers, or excessive clinical details. Keep it minimal and relevant to learning.
3.
Link to change. Identify specific actions, reading, practicing, proposing fixes. Share learning appropriately. Look after yourself. Engage in debriefing with senior supervisor. Signpost to well-being support if needed after an error. Find the free SJT textbook and podcasts at passthemsra.com and subscribe at youtube.com at passthemsra.
Individual reflection is one part. Organizational learning from adverse events, and indeed even near misses, is another critical piece of the puzzle to continuously enhance patient safety across the board.
Yes, learning from adverse events. This is a systematic process involving recording the event, deciding on a proportionate response, compassionately involving all those affected, patients, families, and staff, identifying underlying system factors, implementing effective actions, and evaluating their impact. This continuous cycle drives improvement in patient safety across the NHS.
What are the key systems here?
The LFPSE, Learn from Patient Safety Events, is the National Digital Service for Recording and Analysis. You should submit events promptly. The PSIRF, Patient Safety Incident Response Framework, guides organizations in responding with proportionate, systems-focused approaches, and it mandates compassionate engagement with all affected parties, including staff.
And the culture.
A just culture, or being fair, is crucial. It means responding to incidents fairly and consistently, supporting speaking up and learning, rather than immediately seeking to blame individuals. Actions implemented should be SMART, specific, measurable, achievable, relevant, time-bound, with clear owners and deadlines.
Common pitfalls. Blaming individuals.
Yes, immediately seeking to blame individuals rather than focusing on identifying and learning from system failures. Tempting, maybe, but wrong as it discourages reporting and prevents true learning. Investigating every incident the same way, regardless of severity, PSIRF emphasizes proportionality, failing to provide feedback to those affected about learning and actions, keeping findings confidential, preventing wider sharing, and not tracking the implementation or impact of actions, leading to no real change.
Okay, classic scenario. A wrong site surgical block, injecting a local anesthetic on the wrong side, is identified and averted at the timeout stage in theater. No harm occurred. Best next step.
You should immediately record this new miss on the LFPSE system. It is also appropriate to inform the patient with candor about the near miss, explaining what happened and the steps taken to prevent harm and future recurrence. Agree on a proportionate PSRF review to understand the system failures, why did it nearly happen, and ensure the learning is shared with the theater team.
And just carrying on.
Carrying on is normal because no harm occurred, misses a critical learning opportunity that could prevent actual harm next time. Blaming the anesthetist in writing is unprofessional, unhelpful, and goes against just culture principles.
Got it. Memory hook. PRISM. Proportionate root system factors involve SMART actions. Monitor.
And the rapid checklist for the exam.
1.
Record. Submit event on LFPSE promptly. Capture facts accurately.
2.
Engage. Inform and involve patients, families, staff compassionately. Agree contact preferences.
3.
Analyse. Select proportional investigation. Huddle, review, full investigation, focusing on system factors, not just individuals.
4.
Implement SMART actions, assign owners and deadlines. Share and check. Feedback learning to affected parties. Monitor impact of changes. Revisit if risks persist. Find the free SJT textbook and podcast at passthemsra.com and subscribe at youtube.com at passthemsra.
And finally, after an adverse event, it's not just about system learning. It's also crucially about compassionately supporting the colleagues who were involved, who can often become, as we say, second victims of the incident themselves.
Yes, supporting colleagues after incidents. This means offering immediate compassionate check-ins, ensuring psychological safety, fair treatment based on a just culture, and providing practical help with both the candor and learning processes. This is crucial because staff involved can experience significant emotional distress and professional impact.
What guidance backs this up?
The PSIRF Engagement Guide specifically mandates the compassionate involvement of patients, families, and staff. A just culture ensures responses are fair and consistent, supporting staff without fear of unfair blame. And you should support colleagues to meet their apology and candor duties, reminding them apologizing is right and not an admission of liability. Offer structured support like senior review, debriefings, formal supervision, and signposts to confidential well-being services like occupational health or their educational supervisor.
Common pitfalls. Gossiping.
Yes, gossiping or immediately assigning blame before facts are established. Tempting, perhaps, but wrong as it creates a toxic environment and inhibits learning. Leaving a distressed colleague to apologize alone without support. Neglecting welfare follow-up, assuming they'll just get over it, ignoring distress or telling them to tough it out, and imposing immediate punitive measures without a full, fair investigation.
Okay, classic scenario. An FY1 doctor is visibly tearful and distressed after inadvertently administering an insulin overdose. The patient is now stable. Best next step.
You should immediately remove the FY1 from clinical duties if they are distressed and arrange for a senior review and a debriefing session for them. Support them in having a timely, coached candor conversation with the patient. Ensure the incident is documented and logged on LFPSE, and crucially, plan follow-up for their welfare.
And telling them to just carry on.
Telling them to carry on and be more careful ignores their distress and the learning opportunity and is potentially unsafe if they're impaired by distress. Emailing the entire department naming the FY1 is highly unprofessional and shaming.
Got it. Memory hook. 3 C's, care for colleague, candor, culture just.
And the rapid checklist for the exam.
1.
Immediate check-in, ensure colleagues safe, remove from clinical tasks if distressed, arrange cover.
2.
Practical support. Facilitate senior review, debrief, ensure access to supervision, signpost well-being servicization. 3. Fair process. Ensure incident handled per PSIRF just culture. Avoid premature blame. Focus on systems. Enable candor. Offer coaching support for patient conversation. Be present if appropriate. Ensure documentation reporting duties met.
5.
Follow-up. Conduct check-ins with colleague. Confirm learning actions implemented. Ensure ongoing support. Find the free SJT textbook and podcasts at passthemsestway.com and subscribe at youtube.com at passthemsra.
Moving from the critical processes of dealing with errors, let's pivot now to something equally vital for your long-term career: self-care and resilience. Taking care of our patients is, of course, the priority, but taking care of ourselves is absolutely crucial to making that possible sustainably.
Indeed. Section 9, self-care and resilience, starting with recognizing burnout. Now, burnout, as defined by ICD-11, is specifically an occupational phenomenon resulting from chronic, unmanaged workplace stress. It's not just feeling tired.
Right. It has those 3 key dimensions.
Exactly. Feelings of energy depletion or exhaustion, increased mental distance or negativity towards one's job, and reduced professional efficacy or accomplishment. Recognizing these signs early is crucial to protect both yourself and, ultimately, your patients.
What does the GMC say?
GMC Good Medical Practice 2024 is clear. You must recognize and work within your limits of competence and capacity, seek advice and supervision when needed, and crucially, act if your own health or well-being could pose a risk to patient safety. The HSE management standards for stress also highlight employers' duties to mitigate work-related stressors.
So what are the key signs we should be looking out for in ourselves or colleagues?
Persistent exhaustion that doesn't resolve with rest, increased irritability or cynicism, maybe an increase in errors or near misses, a pervasive dread of going to work, feeling emotionally detached from duties or patients. These are all red flags.
And the big pitfall, trying to power through.
Yes, attempting to push through significant fatigue or impairment despite clear risks to patient safety. Tempting, we all feel pressure, but wrong as it endangers patients and yourself. Hiding concerns due to fear of stigma or appearing weak, blaming individuals rather than acknowledging systemic factors like workload, and never taking leave or maintaining an unsustainable workload.
Okay, classic scenario. You're on an overnight shift, feel profoundly exhausted, maybe made a couple of small slips or near misses already. Best next step.
Your immediate priority is patient safety. You must inform the nurse in charge or your senior colleague that you are feeling unsafe to continue functioning properly. Request a redistribution of urgent tasks, plan for proper breaks, document your concern, and importantly, seek formal help, maybe through practitioner help after your shift ends.
And just carry on.
Saying nothing and carrying on risks serious patient harm. Going home without informing anyone constitutes abandonment of duty and is highly unprofessional and unsafe.
Got it. Memory hook. 3 Ds. D-store. Drain, distance, drop in efficacy. The ICD-11 triad for burnout.
And the rapid checklist for the exam.
1.
Notice signs. Be vigilant for persistent exhaustion, irritability, increasing errors, near misses, dread of work, detachment.
2.
Protect safety. If impaired, pause. Escalate workload risks to senior ANIC. Arrange handover of time-critical care. Get help. Speak confidentially to supervisor occupational health. Consider self-referring to NHS practitioner health, confidential service for doctors.
4.
Adjust work. Prioritize high-risk tasks, defer non-urgent ones, request temporary rota-flexible working adjustments if appropriate.
5.
Record and review. Document your action plan and set a review date. Continue engaging in reflective practice about workload well-being. Find the free SJT textbook and podcasts at passthemsra.com and subscribe at youtube.com at passthemsra.
Recognizing burnout is that crucial first step. The next is proactively seeking the specific help you need for your stress and mental health, something that is, thankfully, increasingly encouraged and seen as a hallmark of a professional, not a weakness.
Absolutely. Seeking help for stress mental health. This means proactively accessing appropriate support, whether clinical, occupational, or organizational, when stress, mental health issues, or maybe even substance misuse might affect your well-being, or, crucially, patient safety. It's a mark of professionalism and responsibility.
And the GMC reinforces this.
Yes, GMC Good Medical Practice 2024 explicitly states you must recognize your limits, seek appropriate supervision, and act to protect patients if your health condition could impact the care you provide.
And where can doctors turn?
NHS Practitioner Health is vital-free, confidential mental health and addiction service specifically for doctors and dentists in England. It's self-referral, which is key.
Yeah.
The BMA services also offer free 24/7 counseling and peer support to all UK doctors and medical students, regardless of BMA membership. These are excellent resources.
So the message is, don't wait.
Exactly. A common pitfall is waiting until a crisis point or working unsafely before seeking any help. Tempting to delay, but wrong as it endangers patients and yourself. Allowing fear of stigma to prevent disclosure to a supervisor or appropriate professional. Not using the dedicated confidential services available. And relying solely on informal support without seeking professional guidance when needed.
Okay, classic scenario. You are mid-shift and begin to experience significant symptoms of anxiety or panic, maybe feeling unable to practice safely. You know a safe handover is needed. Best next step.
Again, immediate priority is patient safety. You must inform your senior colleague or the nurse in charge that you are unable to continue safely. Hand over any critical tasks immediately. Try and take a short break to compose yourself, maybe step away for 5 minutes. And contact a confidential support service like NHS Practitioner Health or the BMA counseling line as soon as practicable. Document the handover and agreed plan, and agree on a review time with your senior.
And just leaving.
Leaving without telling anyone constitutes abandonment, extremely unprofessional and unsafe. Hiding your symptoms and trying to carry on risks significant patient harm.
Got it. Memory hook. 3 lines of support. Senior, Supervisor OH, Practitioner Health, BMA 247.
And the rapid checklist for the exam.
1.
Immediate safety. If feel impaired, inform senior ENIC, share workload, arrange cover if needed. Access support. Self-refer to NHS Practitioner Health, contact BMA counseling peer support, consider OH or GP.
3.
Plan adjustments. Discuss agreed temporary rota changes or flexible working with supervisor, set clear review date. Record and confidentiality. Document decisions actions. Share info on need-to-know basis, respecting own confidentiality. Find the free SJT textbook and podcasts at passthemsra.com and subscribe at youtube.com at passthemsra.
A key aspect of self-care and preventing the need for that kind of crisis intervention is actively maintaining a healthy work-life balance throughout your career. Easier said than done sometimes, but crucial.
Definitely. Maintaining work-life balance in medicine. This involves achieving a sustainable workload and ensuring predictable rest. It's achieved through proactive rota planning, setting clear professional boundaries, and utilizing NHS flexible working arrangements fairly for both yourself and your colleagues, all while ensuring safe staffing levels are maintained.
Is there official support for flexible working?
Yes, the NHS People Promise and its flexible working policy framework state you have the right to request flexible working from day one of employment. The policy focuses on ensuring predictability and fairness. GMC Good Medical Practice 2024 also instructs you to work within your competence and capacity and raise concerns promptly if safety is at risk due to workload or fatigue.
And employer responsibilities.
The HSE stress standards highlight employers' responsibilities to assess and manage work-related stressors impacting well-being. And personally, proactively plan your annual leave, ring-fence protected rest periods, avoid working unsafe consecutive shifts, check your contract limits.
Common pitfalls. Secret shift swaps.
Yes, engaging in secret swaps of shifts with colleagues or leaving a shift without formal cover, leading to unsafe staffing. Tempting for convenience, but wrong as it compromises safety. Practicing presenteeism, attending work despite being impaired by fatigue or illness, rather than taking time off. Never taking annual leave or refusing rest time, which massively increases burnout risk, and refusing flexible working requests from colleagues without a fair, transparent, documented reason based on service need.
Okay, classic scenario. You need to attend a significant, once-in-a-lifetime family event that falls on a date you're scheduled for a clinical shift next month. Best next step.
Your best approach is to submit a formal flexible working or rota change request well in advance. Crucially, you should proactively propose named equivalent cover for your shift and outline any mitigation plans for a potential impact. Ensure this agreement is confirmed in writing with the rota coordinator or manager.
And just swapping on WhatsApp.
Swapping shifts informally on WhatsApp without informing anyone creates safety risks the rota might not reflect who is actually working, which is dangerous. Calling in sick on the day is unprofessional and undermines trust.
Got it. Memory hook. Use the UID grid, urgent, important, delicate, for workload, but also think about protecting personal important events fairly.
And the rapid checklist for the exam.
1.
Plan ahead, plan leave risk, avoid unsafe shifts, request flexible working early with impact mitigation plan.
No.
Be fair, ensure transparency in swaps, confirm cover has equivalent competence skills.
3.
Protect breaks. Actively take breaks. Escalate promptly if repeatedly unable to take safe breaks. Document and review. Document agreed flexible working shift changes. Regularly review adjust work-life balance. Find the free SJT textbook and podcasts at passthemsra.com and subscribe at youtube.com at passthemsra.
Maintaining work-life balance involves proactively managing your workload, but it also fundamentally relies on the critical ability to recognize your own limitations as a clinician, knowing when to ask for help.
Yes. Recognizing own limitations. This means accurately matching tasks to your current competence and capacity. It involves proactively seeking appropriate help and supervision, and crucially, protecting patients by escalating early when a situation or task is beyond your abilities or experience. This is a core professional competency, not a failing.
And the GMC is very clear on this.
Explicitly, GMC Good Medical Practice 2024 says you must recognize your limits, only practice with suitable supervision, actively ask for help when needed, and always ensure patient safety is your paramount concern. The GMC guidance on raising and acting on concerns also instructs you to take prompt action if safety might be compromised, including when you identify your own limitations impacting care.
So, asking for help is good.
Seeking help is not a sign of weakness. It's fundamental professional practice and contributes directly to safer patient care.
What are the common pitfalls then? Trying to wing it.
Exactly. Attempting to wing it or have a go in high-risk procedures or complex clinical scenarios you've never performed or been trained for, tempting to seem capable but wrong as it directly risks patient harm, delaying escalation to a senior to save face, or avoid appearing less competent. Poor or vague documentation of decisions made when escalating or the supervision received, and refusing to see a patient because you feel out of your depth without taking responsibility to arrange safe alternative cover. That's abandonment.
Okay, classic scenario. You're asked to insert a specific medical device, say a chest drain or a central line, that you have never performed before, and you know you lack the necessary experience and sign-off. Best next step.
You should politely but clearly explain your limitation to the senior colleague or team requesting it. Your immediate action is to ensure patient safety measures are maintained, for example, monitoring. Then, you must call an experienced clinician, your registrar or consultant, to perform or supervise the procedure. Actively assist them to learn from the situation and ensure the decision and supervision level are thoroughly documented.
And just trying it.
Attempting the procedure alone to have a go is highly unsafe and unprofessional. Refusing to see the patient without offering an alternative plan or arranging cover is abandonment of duty.
Got it. Memory hook. Stoppy. Stop. Talk options plan.
And the rapid checklist for the exam.
1.
Assess risk. If task situation is unfamiliar, high risk, complex, pause and assess your capability honestly.
2.
Seek supervision. Immediately call senior consultant. Consult relevant guidelines. If urgent, allocate task to competent colleague.
3.
Be transparent. Communicate clearly with patients about who will be reviewing them or supervising, and next steps. Document. Meticulously document your decision to escalate, advice received, and plan implemented, including level of supervision. Find the free SJT textbook and podcasts at passthemsra.com and subscribe at youtube.com at passthemsra.
And finally, in this section on self-care, let's address the often unspoken yet profoundly important aspect: managing the emotional impact of clinical work itself. it can take a toll.
Absolutely. Managing emotional impact of clinical work. This involves recognizing normal stress reactions to challenging situations, proactively accessing peer and organizational support mechanisms, and acting decisively if symptoms of distress persist or begin to impair your professional or personal functioning, thinking about things like PTSD symptoms. This is crucial for sustained well-being and safe practice.
What kind of support mechanisms are there?
Things like Schwartz rounds. These are multidisciplinary forums designed for healthcare staff to reflect on the emotional and social aspects of patient care. Studies suggest they can reduce psychological distress and improve team connection.
And if things get more serious?
NICE guideline NG-116 for PTSD provides guidance on recognizing symptoms, offering initial information, monitoring early signs, and referring for specialist support if symptoms are persistent or impairing function. The PSIRF engagement guidelines also emphasize compassionate involvement and support of staff after incidents, fostering that just culture where learning is prioritized over blame.
And basic self-care.
Vital. Prioritizing fundamental strategies, adequate sleep, good nutrition, physical activity, allowing yourself time off after particularly traumatic events when possible.
Common pitfalls, suppressing emotions.
Yes, attempting to tough it out or suppress emotions after traumatic cases. Tempting maybe seems strong, but wrong as it can lead to unaddressed psychological distress and long-term negative consequences. Engaging in gossip or blame culture after incidents rather than fostering a just learning environment. Skipping follow-up or assuming a colleague is fine when distress persists beyond a few weeks. Ignoring signs of distress in yourself or colleagues, or telling them to move on or get over it.
Okay, classic scenario. After a particularly traumatic shift, maybe a pediatric death on call, a colleague starts showing signs of persistent nightmares and avoidance behaviors 4 weeks later. Best next step.
You should compassionately offer a debrief with a senior or peer and maybe suggest attending a Schwartz round if available. Advise your colleague about the information and monitoring recommendations from NICE NG-116 for PTSD signs, and crucially, signpost them to confidential support services like their GP or NHS practitioner health, ensuring a plan for follow-up is considered.
And telling them to just move on.
Suggesting they move on and avoid discussing it or telling them to toughen up is unsupportive, unprofessional, and could potentially worsen their distress.
Got it. Memory hook. HLT before big decisions or when feeling overwhelmed. Are you hungry, angry, lonely, tired? If so, pause and reset before acting.
And the rapid checklist for the exam.
1.
Name and normalize. Debrief with senior peer. Offer attend Schwartz rounds to process emotions. Self-care and boundaries. Prioritize sleep, nutrition, movement. Allow time off after trauma if possible.
3.
Watch for red flags. Be alert for persistent PTSD symptoms, nightmares, avoidance, hyperarousal impairment. Signpost to GP practitioner health. Consider NICE NG-116 referral.
4.
Support others. Check in on distressed colleagues. Signpost BMA counseling peer support. Facilitate supervision access.
5.
Document and learn. Engage in anonymized reflective practice. Feed insights into PSIRF learning processes if appropriate. Find the free SJT textbook and podcasts at pastthemsra.com and subscribe at youtube.com at pastthemsra. Right, moving from the essential self-care that sustains us as professionals, let's pivot to our profound ethical duty to protect others, safeguarding. This is the critical area of identifying and responding to concerns for children and vulnerable adults.
Absolutely. Section 10. Safeguarding and vulnerable groups. Starting with child safeguarding. Signs, referral, documentation. This encompasses protecting children and young people from abuse, neglect, exploitation, and actively promoting their welfare. For frontline clinicians, it means recognizing concerns, sharing info appropriately, and making timely referrals.
What's the core guidance?
Practice is guided by working together to safeguard children, 2023, and the Children Act, 1989. You must refer to children's social care if there's 1. Reasonable cause to suspect significant harm, that's Section 47, or 2. A child is a child in need requiring support, Section 17.
And information sharing. Consent needed.
This is crucial. You do not need consent to share information for safeguarding purposes where there's a lawful basis, like risk of harm, and it's necessary and proportionate. You must record your rationale, share the minimum necessary information on a need-to-know basis using secure channels.
What about MAH?
The FSH, Multi-Agency Safeguarding Hub, usually acts as the front door, the multi-agency triage and info-sharing hub for new child referral.
Any specific clinical red flags?
Yes, RCPCH evidence highlights that bruising in premobile infants, babies not yet crawling or walking, is rare and must be treated as a red flag, requiring urgent senior pediatric review and safeguarding referral. Don't ignore bruises on babies who can't move themselves.
Common pitfalls. Promising confidentiality.
Yes. Promising a child absolute confidentiality or delaying referral to get consent from parents. Tempting, but wrong as it compromises safety and is contrary to guidance. Making minimal notes without verbatim quotes, body maps, or specific dates times. Trying to manage complex concerns alone instead of promptly referring. Not recognizing any bruise on a premobile infant as high risk. And asking detailed, leading questions that could contaminate evidence. Just record verbatim disclosure and refer.
Okay, classic scenario. A 4-month-old non-mobile baby presents with a small, unexplained bruise on their cheek. Carer says they knocked a toy bar, but it seems inconsistent. Best next step.
Given bruising in a premobile infant is a red flag, you must immediately arrange a same-day pediatric child protection medical review. Simultaneously, inform your safeguarding lead and make an urgent referral to Children's Social Care, MASH. You must meticulously record the verbatim history and create a body map as per local policy.
And just watching and waiting.
Reassuring the carer and discharging, or waiting to see if another bruise appears, is unsafe and ignores crucial evidence. Asking for photos via WhatsApp is insecure and inappropriate for documentation.
Got it. Memory hook. Child safe. Check safety. Here, child alone. Information share. Need to know. Lead consult. Safeguarding. Document. Section 47. Test. Act on strategy. Family support. S17. Escalate.
And the rapid checklist for the exam? Ensure immediate safety. If imminent danger, call police. 999. Ensure child safe. Inform senior safeguarding team.
2.
Recognize signs. Be vigilant for injuries inconsistent with history, developmental red flags, disclosures, poor care, domestic abuse exposure, neglect.
3.
Record well. Document verbatim quotes. Use body maps. Differentiate fact opinion. Ensure contemporaneous timing. Refer promptly. Contact MNSH same day. If S17, S47 thresholds met likely, consider strategy discussion.
5.
Share lawfully. If consent refused and safe, share under safeguarding public interest basis. Document lawful basis rationale. Find the free SJT textbook and podcasts at passthemsra.com and subscribe at youtube.com at passthemsra.
Just as children require protection, so do vulnerable adults. Understanding adult safeguarding principles is equally crucial, often involving more complex considerations around capacity and autonomy, which we touched on earlier.
Right, adult safeguarding. Vulnerable adults, domestic abuse. This is about protecting an adult who has care and support needs and is experiencing or is at risk of abuse or neglect, and who, as a result of those needs, is unable to protect themselves. These specific criteria usually trigger a Section 42 inquiry by the local authority under the CARE Act 2014.
And the principles guiding this.
All adult safeguarding should follow the 6 principles, SEIE. Empowerment, prevention, proportionality, protection, partnership, and accountability. Think making safeguarding personal, centering on the adult's desired outcomes.
What about domestic abuse specifically?
The Domestic Abuse Act 2021 gives a comprehensive legal definition, including controlling coercive behavior, psychological, physical, sexual, economic abuse, and crucially recognizes children as victims if they witness it. You should use the -H risk checklist to assess risk. High-risk cases get referred to MAAC for multi-agency safety planning.
Common pitfalls. Not recognizing coercive control.
Yes, not recognizing subtle forms like coercive control as serious. Insisting on consent to share info when unsafe, for example, perpetrator present. Failing to complete a -H or make a MARAC referral for high-risk cases. Ignoring making safeguarding personal. Interviewing the adult with the suspected perpetrator present, never do that. And not treating non-fatal strangulation as a red flag emergency.
Okay, classic scenario. A 32-year-old woman with care needs attends with her partner, who answers all questions for her. You notice faint bruises. She avoids eye contact, says she's clumsy. Best next step.
You must find a reason to speak to her alone, in a safe, private space. Validate her experience, explore her safety non-judgmentally. Ask what she wants to happen, making safeguarding personal. Assess risk using DISH if appropriate. With her consent, or if risk is high and in public interest, share limited necessary info with safeguarding services. Document everything meticulously, provide safety netting advice helpline numbers discreetly.
When accepting the partner's version,
Accepting the explanation without private inquiry or inviting the partner in to hear both sides directly compromises safety and autonomy. Telling her you can't do anything without written consent might be wrong if risk is high. Posting on WhatsApp is obviously inappropriate.
Memory hook. The 6 principles, PPPPPA, prevention, proportionality, protection, partnership, accountability, empowerment.
And the rapid checklist for the exam. Make safe and listen. Ensure immediate safety. Conduct private, non-judgmental inquiry. Consider capacity immediate risks.
2.
Assess and act. If S42 criteria likely met, refer to adult social care. For domestic abuse, complete D-H, consider MA@R.
3. Information sharing. Share without consent if threat of serious harm public interest. Record lawful basis proportionality.
4.
Support and signpost. Identify signpost specialist support. IDVAAISVA, safeguarding team, police. Help with safety planning. Document clearly. Accurate contemporaneous notes. Risks, wishes, actions, info shared. Find the free SJT textbook and podcasts at passthemsra.com and subscribe at youtube.com at passthemsra. Both child and adult safeguarding often involve recognizing patterns of neglects, which can be really subtle, can't they? But cumulatively devastating and require specific attention.
Absolutely. Recognizing neglect. Child neglect is that persistent failure to meet basic physical, emotional, or psychological needs, leading to serious impairment of health or development. Adult self-neglect is a broader Care Act category covering lack of self-care for hygiene, health, home environment, often including hoarding. Recognizing patterns and acting proportionately is vital.
What's the key concept here?
Cumulative harm. Multiple small signs of neglect, taken together over time, can meet safeguarding thresholds for significant harm. Building a chronology, maybe using body maps if policy allows, helps capture this pattern.
And adult self-neglect. Is it always safeguarding?
It's assessed case by case whether a Section 42 inquiry is needed. Depends on capacity, risk level, and ability to protect themselves. Proper information sharing and documentation are paramount. Lawful sharing is permitted for safeguarding, and clear contemporaneous notes are essential. Referrals go to MASH for children, S17, S47. Adult social care for adults, consider S42.
Common pitfalls. Thinking incident by incident.
Yes, applying a single incident mindset, failing to see the pattern and cumulative harm. Tempting if each instance seems minor, but wrong as it misses the severity. Assuming adult self-neglect never triggers S42, leading to inaction in high-risk cases. Vague, non-chronological records. Monitoring only without active interventions or referrals. Ignoring associated risks like fire hazards and hoarding.
Okay, classic scenario. A 3-year-old child repeatedly arrives at clinic or ED, appearing hungry, unwashed, immunizations significantly delayed, missed. Best next step.
You must document a detailed chronology of concerns, including verbatim observations and quotes. Make a same-day referral to Children's Social Care, MAH, under the Child in Need, S17, or Significant Harm, S47 threshold. Discuss with your safeguarding lead if unsure which. Liaise with other professionals involved, health visitor, school nurse, and share information lawfully to protect the child.
And just suggesting vitamins?
Suggesting vitamins and rebooking in 3 months is inadequate and unsafe. Waiting for explicit parental consent to share info delays crucial safeguarding and isn't required if there's a risk of harm.
Memory hook for adult self-neglect. CHOA, cleanliness, health organization, risk fire engagement.
And the rapid checklist for the exam.
1.
Recognize patterns. Alert for signs. Missed appointments, poor growth, children, poor hygiene, unsafe home, hoarding adults. Record and chronologize. Document clearly, fact versus opinion, verbatim quotes, body maps, photos per policy, build chronology.
3.
Refer escalate. Children to MSH, S17, S47, adults to adult social care, consider S42, follow self-neglect guidance. Multi-agency liaison. Liaise with schools, GPs, therapy, housing. Consider specific risks, hoarding fire. Involve relevant services. Find the free SJT textbook and podcasts at passthemsra.com and subscribe at youtube.com at passthemsra.
All these safeguarding responsibilities, as you mentioned, require pretty seamless collaboration across various agencies and professionals. Knowing who does what in that multi-agency landscape is really critical for effective protection.
Definitely. Multi-agency safeguarding roles. This involves coordinated work across statutory partners and specialist panels to assess risk, plan safety, and learn from cases. Understanding who does what, MASH, LOTO, MARAC, MAPA, ensures referrals go to the correct door and are handled effectively.
How are the main players for children?
The statutory safeguarding partners are the local authority, the Integrated Care Board, ICB, and police. They lead local arrangements as per Working Together to Safeguard Children 2023.
And MAH is the front door.
Usually, yes. MSH, Multi-Agency Safeguarding Hub, is the central triage and info-sharing hub for new child safeguarding referrals, and sometimes interfaces with adult safeguarding too.
Now, LAU is important for allegations against staff, right?
Critically important. You must inform the LAU, local authority designated officer, within 1 working day of any allegation that a person working with children, staff or volunteer, has behaved in a way that harms a child or is unsuitable to work with children. A common pitfall is reporting these allegations via normal safeguarding channels instead of the specific LADO route. Tempting, but wrong.
What about EMA and MARIFA?
MARAC, Multi-Agency Risk Assessment Conference, is the key forum for managing highest-risk domestic abuse cases, usually identified via DHH. It coordinates a multi-agency safety plan. MARTE, Multi-Agency Public Protection Arrangements, is the statutory framework for managing certain sexual and violent offenders in the community health engages via named leads, or SPOCs, single points of contact.
More pitfalls. Not using DHA.
Yes, referring high-risk domestic abuse without completing a DH assessment or connecting with MARAC, failing to document the lawful basis for sharing info in multi-agency contexts, sending vague emails to safeguarding instead of using the specified mechanism.
Okay, classic scenario. A student nurse reports witnessing a healthcare assistant, HCA, roughly handling a child on the ward. Best next step.
You must immediately inform your senior and ensure the child's safety. Then you are professionally obliged to contact the LEO within 1 working day. You must thoroughly document the incident and preserve any evidence, and importantly, support the student nurse who raised the concern. Whistleblower protection applies.
And just telling the HCA off.
Telling the HCA to apologize and move on, or waiting to see if anyone else complains, ignores serious professional misconduct and a potential safeguarding concern, and bypasses the required LADO process.
Got it. Memory hook. 4 M's of multi-agency, MARAC, MARIGO.
And the rapid checklist for the exam.
1.
Identify right route. Correctly identify MASH, LADO, MARAC, MAPA.
2.
Share proportionately and lawfully. Minimum necessary info, secure channels, record lawful base outcome.
3.
Use SBR in detail. When referring, use SBR, include chronology, risk tools.
4.
Confirm and follow up. Confirm referral receipt. Understand next steps from receiving agency. Find the free SJT textbook and podcasts at pastthemsra.com and subscribe at youtube.com at pastthemsra.
Okay, our discussion on safeguarding naturally leads us into the broader issues of cultural awareness and equality, ensuring everyone receives the care they need, respectfully and without prejudice.
Absolutely. Section 11, cultural awareness and equality. Starting with respecting cultural and religious beliefs. This means actively exploring how a person's culture or religion affect their healthcare decisions and preferences. It involves offering safe and reasonable alternatives where possible, and critically, avoiding assumptions or stereotyping. Vital for patient-centered, ethical, legally compliant care.
Legal basis again.
The Equality Act 2010 is fundamental. Religion or belief is a protected characteristic, making discrimination unlawful. GMC Good Medical Practice 2024 requires fair treatment, ensuring personal views don't affect care, prioritizing solely by clinical need. NICE NG 197 shared decision-making encourages deciding with people, clear communication, using decision aids, and the Accessible Information Standard, AIS mandates meeting communication needs, including professional interpreting.
Pitfalls. Stereotyping.
Yes, stereotyping patients based on cultural, religious background is a big one. Tempting to make assumptions, but wrong as it denies autonomy. Using relatives as interpreters without proper consent documentation or involving children in sensitive talks again risks accuracy, confidentiality, coercion, imposing your own personal beliefs. Poor documentation of preference plan. Dismissing beliefs or refusing care based on them.
Classic scenario again. Patient clearly refuses blood products for religious reasons. Elective surgery planned. Best next step.
Respectfully explore their values, beliefs. Confirm capacity. Discuss all reasonable alternatives to transfusion and their risks. Involve anesthetic surgical teams to plan blood-sparing strategies. Document the comprehensive discussion. Respect their decision. Provide safety netting advanced care planning.
And coercing them.
Coercing consent because it's safest or refusing treatment outright is a serious breach of autonomy and ethics. Delaying the discussion avoids responsibility.
Memory hook. Ask a leaf. Ask your safety options. Keep notes, beliefs, evidence, limits, interpreter, exceptions, follow-up.
And the rapid checklist for the exam. Ask first. Initiate conversation with open questions. Any beliefs practices we should consider.
2.
Clarify impact. Discuss specifics. Modesty chaperone, fasting, blood refusal, prayer, diet.
3.
Shared decision-making. Present options, risks, alternatives, use teach-back. Support access. Arrange professional interpret accessible info per AIS. Allow time privacy.
Aye.
Document and plan. Record preferences, agreed safe plan, provide safety netting follow-up. Find the free SJT textbook and podcasts at passthemsra.com and subscribe at youtube.com at passthemsra.
Respecting cultural and religious beliefs is, of course, a core component of avoiding discrimination, which is fundamental legal and ethical duty for all healthcare professionals.
Exactly. Avoiding discrimination. In healthcare, this is unlawful, unfavorable treatment based on a protected characteristic. It directly harms access, compromises safety, erodes trust. Your professional duty is to actively prevent it and act decisively when it occurs.
Remind us of the protected characteristics.
The Equality Act 2010 prohibits discrimination across 9: age, disability, gender reassignment, marriage, civil partnership, pregnancy, maternity, race, religion or belief, sex, and sexual orientation.
And GMC guidance.
GMC Good Medical Practice 2024 is clear. Treat patients fairly, don't refuse delay care because you disagree with their choices, prioritize care solely by clinical need, not personal bias. Understand the different types of discrimination too: direct, indirect, harassment, victimization, and the specific duty for reasonable adjustments for disability. NHS bodies also have a public sector equality duty, PSED, to eliminate discrimination, advance equality, foster good relations.
Common pitfalls, letting jokes slide.
Yes, leaving derogatory jokes or subtle microaggressions unchallenged. Tempting to avoid confrontation, but wrong as it normalizes discrimination. Implementing one-size-fits-all processes causing indirect discrimination, e.g. only online booking. Failure to provide reasonable adjustments or AI support. And judging a patient's choices or lifestyle and refusing delaying care explicitly prohibited by GMC.
Classic scenario. Receptionist says, "We don't book interpreters here, bring a relative," to a non-English speaker. Best next step.
You must intervene immediately. Politely but firmly explain this is unacceptable practice, it breaches the AIS. Arrange for a professional interpreter and accessible information as per the standard. Document the incident thoroughly and escalate it to appropriate management.
And doing nothing.
Doing nothing or asking the patient's child to interpret is discriminatory, unprofessional, compromises safety and confidentiality.
Memory hook. 4 T's. Treat fairly, tackle bias, tailor access, track outcomes.
And the rapid checklist for the exam.
1.
Spot and stop. Challenge discriminatory remarks behavior courteously but clearly. Offer immediate support to those affected.
2.
Adjust and include. Actively make reasonable adjustments. Accessible info, physical access, longer appointments.
3.
Escalate and record. Follow local policy to report incidents, statistics, document facts and outcomes. Reflect and learn. Share learning from incidents to improve processes and prevent recurrence. Find the free SJT textbook and podcasts at passthemsra.com and subscribe at youtube.com at passthemsra.
Avoiding discrimination is really the baseline, isn't it? Providing truly equitable care goes a step further, proactively addressing individual patient needs to ensure fair outcomes for everyone.
Yes, providing equitable care to all patients. Equitable care is about tailoring access, information, and follow-up to a person's unique needs language, disability, culture, health literacy, digital access so that outcomes are fair. It's about removing barriers so care is reachable, understandable, acceptable to everyone. Recognizing that equality, treating everyone the same, doesn't always lead to equity, fair outcomes.
What guidance supports this?
NICE Guideline CG 138 on patient experience stresses creating the best experience, encouraging preferences, ensuring continuity. NICE Guideline NG 197 focuses on embedding shared decision-making and clear risk communication. And the Accessible Information Standard, AIS, is mandatory: identify, record, flag, meet, review communication needs. NHS organizations also have legal duties to meet equality and health inequalities duties.
Common pitfalls. Treating everyone the same when needs differ.
Yes, giving equal time or resources when some patients clearly need longer appointments or more tailored support, leading to unsafe understanding. Tempting for efficiency, but wrong as it fails equity. Failing to provide professional interpreters or accessible formats. Offering digital-only access without clear alternatives. Declining necessary adjustments due to policy or inconvenience. Relying on family to interpret complex info without professional oversight.
Okay, classic scenario. A non-English speaker is booked for an urgent consent discussion, but no professional interpreter has been arranged. Best next step.
You must immediately rearrange the appointment urgently to ensure a professional interpreter can be present. In the interim, provide any translated or accessible written information available. Critically, document the AIS flag in the patient's record and the reasons for delay and the plan.
And just trying with gestures.
Asking the patient's teenager to translate places undue burden, risks inaccuracies, breaches confidentiality. Attempting with gestures is unsafe and compromises true informed consent.
Memory hook.
Yeah.
Flag gate for equitable care. Flag needs language, access, guidance, decision aids, interpreter time.
And the rapid checklist for the exam.
1.
Identify barriers. Actively ask about language, format, disability, transport, caring issues hindering access understanding.
2.
Adjust care. Arrange professional interpreter, provide easy read BSL, offer quiet room, involve carers with consent, offer longer appointments if needed,
Right.
share decisions and teach back, confirm understanding using teach back, use decision aids, coordinate services, liaise with PPs, community teams, provide safety netting, clear follow-up plans.
5.
Document flags. Record patient needs communication preferences prominently in record, e.g. AIS flags. Find the free SJT textbook and podcasts at passthemsra.com and subscribe at youtube.com at passthemsra.
And providing that kind of equitable care directly contributes to addressing the wider health inequalities within our communities, doesn't it? Striving for a fairer and healthier society for all.
Absolutely. Addressing health inequalities. These are those unfair, avoidable differences in health status between different population groups. The NHS uses frameworks like Core 20 PLUS 5 to focus action on reducing these inequalities nationally and locally by targeting specific populations and clinical priorities. Addressing them is a core duty of all NHS bodies.
Break down Core 20 PLUS 5 for us.
Core 20, the most deprived 20% of the national population, by Index of Multiple Deprivation, IMD. Aim is to narrow health gaps for this group. PLUS, locally defined groups experiencing worse access, experience, or outcomes, like inclusion health groups, rough sleepers, sex workers, vulnerable migrants. The 5 clinical areas for adults: current national priorities maternity care, SMI physical health checks, chronic respiratory disease, early cancer diagnosis, and hypertension case finding. There's a similar version for children, young people.
And it's a legal duty.
Yes, NHS ICBs and trusts have explicit legal duties to meet equality and health inequalities, duties in planning and delivery. In SJT scenarios, you should favor options that use data to identify disparities, target support specifically, maybe co-design interventions with communities, and actively measure impact.
Common pitfalls. One size fits all again.
Yes, implementing one-size-fits-all clinics that inadvertently widen health gaps by not addressing specific barriers. Tempting for simplicity, but wrong. Not monitoring service uptake or outcomes by IMD, ethnicity, or specific needs, leading to blind spots. Relying solely on digital access without non-digital alternatives. Waiting for more funding instead of taking immediate targeted action.
Okay, classic scenario. Your primary care network, PCN, is asked to improve hypertension case finding and BP checks in the most deprived estates in your area. Best next step.
The most effective approach would be setting up accessible walk-in clinics, perhaps in evening or weekend slots, ideally in community venues like community centers, not just the GP surgery. Use targeted invitations, not just posters. Ensure professional interpreters and accessible information, AIS, are available. Crucially, monitor uptake by IMD quintile and ethnicity, and iterate your approach by working closely with community connectors or link workers.
And just putting up a poster.
Simply putting a generic poster up in the hospital canteen or GP waiting room is passive and known to be ineffective in reaching underserved groups. Waiting for next year's funding delays, vital public health action.
Got it. Memory hook. T3 for inequalities.
Yeah.
Target. Core 20 PLUS.
Oh.
Tailor barrier busting. Track access experience outcomes.
And the rapid checklist for the exam.
1.
Use data. Identify Core 20 areas local PLUS groups using data. Scan waiting lists for disparities.
2.
Target offers. Design outreach, send targeted invites, offer longer appointments, use community venues, explore transport solutions.
3.
Reduce access barriers. Ensure interpreters AIOEE available. Provide non-digital routes. Offer flexible appointment times. Co-design. Work with community connectors VCSE organizations. Monitor patient experience.
5.
Track impact. Measure uptake outcomes by deprivation, ethnicity, needs, iterate strategies based on findings. Find the free SJT textbook and podcasts at passthemsra.com and subscribe at youtube.com at passthemsra.
Right. Now that we've covered those core ethical, professional, and systems principles that underpin the MSRA SJT, Let's turn our attention briefly to how these principles are actually tested in the various scenario formats you'll encounter in the exam itself. Understanding the technique for each type is pretty crucial for maximizing your score.
Yes. Section 12, Common SJT Scenario Types. First up, best of 3, single best answer scenarios. Here you get a clinical or professional vignette and usually 8 potential actions, AH. Your task is to select the 3 best actions you would take now or next. The options are largely independent, not necessarily a sequence.
So how do you choose the best 3?
The core strategy is to prioritize based on a clear hierarchy. Number 1, always patient safety, address immediate threats to life or limb first, A, B, C, D, E. 2, honesty, candor. 3, escalation supervision, know when to get senior help. 4, documentation. 5, equity and dignity. You should avoid options that involve delay, secrecy, just abdicating responsibility, or breaching professional policy.
Okay, example. 2 deteriorations, short-staffed.
Right. Surgical FY1 covering 28 patients. 2 bleeps simultaneously. Nurse reports new WS2 of 7 with hypotension. Radiology phones with positive CTPE result for another patient. Phone keeps ringing. Pick 3 best actions.
The best 3 would likely be:
A.
Ask nurse to repeat Obstart O2 while you go immediately to the new WS7 patient, sickest first, A, B, C, D, E. B. Call the medreg for urgent review of that patient and ask for IV access fluids prepared, early escalation, parallel tasking. D. Ask the nurse in charge to allocate extra hands and devote non-urgent bleeps, creating capacity, shielding you.
And wrong options.
Things like deferring action on the positive CTPE result or finishing discharge letters first, unsafe delays. Putting jobs on a private to-do list without action or escalation is just hidden work and unsafe. Okay, next type. Rank 5 from best to worst action. This requires more granular judgment.
Yes. Here you get a scenario and 5 distinct actions.
Yeah.
AE, your task is to rank all 5 from absolute best, rank 1, to the absolute worst, rank 5.
How do you approach the ranking?
Your ranking should consistently lead with actions prioritizing. 1, immediate patient safety and time-critical interventions. 2, escalation to senior steams. 3, clear communication, like Candour. 4, thorough documentation and learning. You must heavily penalize options involving delay, unsafe delegation, dishonesty, or discourtesy. The worst options are usually unsafe or dishonest.
Example, chest pain versus paperwork.
You're clerking. New patient with acute chest pain ECG changes arrives versus urgent request to rewrite a drug chart. Rank the 5 options.
The ideal ranking would be: first, attend chest pain immediately, start ACS protocol, delegate drug chart rewrite. Second, inform registrar CAPSIMIC, create capacity, document plan. Third, finish discharges first, lower value but not actively harmful. Fourth, wait for an unrelated CT result, passive delay. Fifth, ask an HCA to keep an eye on chest pain patient while you do paperwork, unsafe delegation, worst action. Rationale, life threat first, then capacity escalation, penalize unsafe delays, delegation most.
Okay, what about trickier ones? Situations with no perfect option. Ah, yes, the classic dilemmas where all options have flaws. Your task is usually to pick the 3 actions that together best protect safety, honesty, fairness, effectively minimizing harm.
So the strategy is harm minimization.
Exactly. Focus on actions that reduce immediate severe risks. Rapid senior input is often key here. Transparency about challenges in your reasoning. Documented reasoning why you chose this path. Avoid unsafe delay, disproportionate responses like excessive restraint, or outright abdication.
Example, impacity, unclear, urgent decision.
Elderly patient, UTI, delirium, refuses urgent IV antibiotics. Capacity fluctuates, registrar 20 minutes away. Pick 3 least harmful actions.
Best options are likely: A, explain risk benefits simply, recheck capacity for this decision, seek assent, maximize capacity. B, if capacity clearly lacking in delay risks harm, start 5 antibiotics under best interest, document thoroughly, urgently inform registrar, time critical best interest plus escalation. G, record capacity assessment and rationale for all decisions contemporaneously, essential documentation.
Waiting hours or using security without assessment would be wrong.
Yes, unsafe delay or disproportionate response. Okay, how about multiple correct but prioritization required scenarios? Lots of good options.
These often appear as rank 5 questions. Several actions seem reasonable, but some are more urgent, impactful, or strategic. The key is ordering by time criticality and risk reduction first, then capacity creation, then communication, then routine admin. Always stabilize, escalate appropriately, create capacity first when facing competing urgencies.
Example, sepsis, high K plus caries, CT result, family update, discharges all at once.
Ideal order. First, start sepsis bundle now, life threat. Second, treat hyperkalemia, repeat ECG, life threat. Third, ask NIC to divert bleep sassine help, create capacity. Fourth, update family after stabilizing, communication follows safety. Fifth, call CT for non-urgent result, least time critical.
And finally, professional dilemmas with conflicting priorities.
These pit values against each other, patient interest versus team pressure, targets versus integrity. You need to identify actions best upholding GMC principles, safety, and fairness, often a pick 3 format.
What values win?
Consistently prefer actions demonstrating candor and integrity. Respect patients, colleagues, process. Escalation for concerns, documentation, avoid convenience, misplaced loyalty, covering up, or compromising ethics safety.
Example: pressure to cut corners on consent for targets.
Best actions. A. Politely decline unsafe shortcut, explain standards, uphold integrity. C. Offer constructive alternative, problem solve. E. If pressure persists, escalate to consultant governance lead, address systemic issue, not just doing as asked.
No, that compromises safety and integrity. Backdating notes is dishonest. Ignoring it is unprofessional.
Great overview of the types. Find the free SJT textbook and podcasts at passthemsra.com and subscribe at youtube.com at passthemsra for more examples.
All right, you've just dived deep into the heart of the MSRA SJT. We've unpacked critical legal frameworks, ethical dilemmas, practical strategies for worse. Let's try and distill our entire conversation into those golden rules that will serve you well, not just in the exam, but frankly throughout your entire medical career.
Okay, rapid fire golden rules. 1.
Safety first. Always, always prioritize immediate patient safety above all other tasks, pressures, or personal considerations. Non-negotiable.
Yeah.
Escalate early. If a situation is beyond your competence or your workload exceeds safe capacity, always speak up. Escalate to a senior colleague or the site team promptly. Don't wait.
3.
Be open and honest. Candor. When things go wrong, however small, tell the patient, offer a sincere apology, clearly explain the known facts and the next steps. Build trust.
Right.
Protect patient data.
Yeah.
Share information lawfully, minimum necessary, strict need-to-know basis, especially when safeguarding. Respect confidentiality.
5.
Use interpreters. Ensure equitable care. Actively provide qualified professional interpreters and accessible information formats when needed. Don't rely on family.
6.
Document everything. Clear, accurate, contemporaneous notes are your best defense and communication tool. Record facts, verbatim quotes where needed, your rationale, and all plans. If it's not written down,
It didn't happen.
yeah.
7.
Respect roles and boundaries, whether in consent, resource allocation, professional conduct. Always adhere to GMC guidance and legal frameworks like the MCA and Equality Act. Know the rules.
And finally, 8.
Know your limits and seek help. It is a mark of true professionalism to recognize signs of burnout or stress in yourself or others, and to proactively access confidential support services available to you. Look after yourself to look after your patients.
And that's our deep dive into the MSRA SJT. We really hope this comprehensive breakdown has been an incredibly useful shortcut to mastering those crucial scenarios and boosting your confidence.
For even more high-yield rules, realistic scenarios, mnemonics, and those rapid checklists, remember you can find the free SJT textbook and other valuable podcasts at https://www.passthemsra.com.
And please don't forget to subscribe to us at https://www.youtube.com at passthemsra to stay ahead in your medical journey. We are genuinely here to help you succeed.
Just a final note, this deep dive is for educational purposes only. Always, always refer to and follow your local trust policies, guidelines, and the most up-to-date national guidance. The MSRA SJT is designed to test your judgment and alignment with UK national standards, and this content is intended to support that learning. Good luck